So, guys, my name is Dr. Wajid Khan. I am an anesthetist and intensivist. So, we'll be dealing with this topic of anesthesia. Let us start with this topic called as nerve blocks. Nerve blocks. Under the nerve blocks, we'll discuss the brachial plexus block, we'll discuss the stellate ganglion block, and we'll discuss the celiac plexus block. Starting with the brachial plexus. Brachial plexus. Now guys, first we need to understand, before blocking the brachial plexus, we need to understand brachial plexus is responsible for what? Brachial plexus supplies what? Brachial plexus supplies the upper limb. It is responsible for the sensory and the motor activity of the upper limb, right? So brachial plexus is formed by C5 till T1, C5, C6, C7, C8 and T1. It is formed by C5 till T1. Why do you want to block the brachial plexus? The reason why do you want to block the brachial plexus is what? You want to block the brachial plexus when the patient is posted for any surgeries of the upper limb, right? So if you want to block the brachial plexus, there are three approaches. There are three approaches to block the brachial plexus. The first approach of brachial plexus, remember guys, if you want to block this brachial plexus, it can be blocked by three routes. What three routes, guys? There are three ways or three approaches to block the brachial plexus. One is called as interscalene approach. Other is called as supraclavicular approach. And last is called as axillary approach. One is interscalene, other is supraclavicular, last is axillary approach. Interscalene meaning what? You introduce your needle between the anterior and middle scalene to find the brachial plexus. Supraclavicular meaning what? You introduce the needle above the clavicle, 1 centimeter above the midpoint of the clavicle to find the brachial plexus. Axillary meaning what? You introduce the needle through the axilla to find the brachial plexus. Which is the most proximal approach among these? The most proximal is what, guys? Interscalene approach. The most proximal is interscalene. The most distal approach, remember the most proximal is interscalene. The most distal approach is what? Axillary approach. Most distal approach of brachial plexus is what, guys? Axillary approach. We are talking about these three approaches: interscalene, supraclavicular and axillary. Starting with what? Interscalene approach. As you go for interscalene approach, interscalene meaning what? Introduce the needle in between the scalene anterior and scalene medius. You introduce the needle. As it is the most proximal approach, it will only block the proximal roots of brachial plexus. What proximal roots? The C5, C6 and C7. Interscalene approach, only the proximal roots are blocked. Right? As it is only blocking the proximal roots, this interscalene approach is used for proximal arm surgeries or best used for shoulder analgesia. Best used for shoulder analgesia. Okay? As it is not blocking the C8 and T1, the main nerve that leaves C8 and T1 is what, guys? Ulnar nerve. Ulnar nerve is spayed. The nerve that could be spayed in interscalene approach is what, guys? Ulnar nerve is spayed. Why it is spayed? Why? Because C8 and T1 is not blocked. But as you are introducing the needle through the anterior and middle scalene, sometimes your needle might damage a nerve called as phrenic nerve that can cause diaphragmatic palsy. Hence, the most common complication of interscalene approaches, the patient develops what? Diaphragmatic palsy due to damage of what nerve? Due to damage of the phrenic nerve. So once again, guys, there are three approaches of brachial plexus. Starting with what approach? Interscalene approach. Remember, guys, interscalene approach. So remember, as I told you, with interscalene approach, only the proximal roots are blocked. only the proximal roots are blocked. What proximal roots are we talking about? What proximal roots are blocked, guys, with interscalene approach, right? The proximal roots such as C5, C6, C7 is blocked. C5, C6, C7 is blocked, right? Hence it is used for proximal arm surgeries, proximal arm surgeries, or it is best used for shoulder analgesia. It is best used for shoulder analgesia. It is used for proximal arm surgeries or best used for shoulder analgesia, right? Shoulder analgesia, right? As C8 to T1 is not blocked, the nerve that is paid over here is what? As C8 and T1 is not blocked, ulnar nerve is paid. Ulnar nerve is spayed. As C8 and T1 is not blocked, what is the nerve that is being spayed? Ulnar nerve is spayed. That's regarding what, guys? Interscalene approach. Interscalene approach. Coming to the next approach of brachial plexus, which is called as supraclavicular. But before going to I told you one thing, guys. What is the most common complication of interscalene approach? The most common complication of interscalene approach of brachial plexus is while introducing the needle, you might damage the phrenic nerve, which can cause what? Diaphragmatic palsy, which can cause ipsilateral diaphragmatic palsy. So the most common complication associated with this approach is what, guys? Diaphragmatic palsy, ipsilateral diaphragmatic palsy, right? Hence this approach should be avoided in the patient. Remember, if a person is suffering with any respiratory disorder and he is having fracture of the upper limb, never go for brachial plexus. Never go for brachial plexus block. Why? Because any approach of brachial plexus will cause respiratory problems. Interscalene approach is causing diaphragmatic palsy due to damage of phrenic nerve. Okay. Coming to the next approach, guys. Coming to the next approach of brachial plexus. What is the next approach of brachial plexus? Supraclavicular. What is supraclavicular, guys? Supraclavicular approach means you are inserting the needle 1 centimeter above the clavicle. Where are you inserting the needle? Needle insertion is 1 centimeter above the midpoint of the clavicle. Midpoint of clavicle. You introduce the needle. This is regarded, the supraclavicular approach is regarded as the best approach of brachial plexus. It is by far the best approach of brachial plexus. Why it is regarded as the best approach of brachial plexus? Why? Because with this approach, with this approach, all the roots are blocked. All the roots are completely blocked. With this approach, all the roots are completely blocked. यानी कि C5, C6, C7, C8, T1, everything will be blocked. Hence, it is the best approach. It could be used for what surgeries of the limb? Almost all surgeries of the limb. Almost all surgeries of the limb. As all the roots are completely blocked, all the roots are completely blocked. As all the roots are completely blocked, it is used for almost all surgeries of the upper limb. Almost all surgeries of the upper limb. Hence, it is regarded as the best approach of brachial plexus. Hence, this is regarded as the best approach of brachial plexus, but comes with a complication. Where are you introducing the needle? You are introducing the needle 1 centimeter above the midpoint of the clavicle. Sometime your needle by mistakenly touches the pleura. What will happen? The most common complication of supraclavicular approach is what, guys? Pneumothorax. The most common complication of supraclavicular approach is what, guys? It is pneumothorax. Pneumothorax is the most common complication of supraclavicular approach. So once again, guys, we are discussing about the approaches of brachial plexus. What approach? We have discussed about the axillary, we have discussed about the interscalene approach, we have discussed about the supraclavicular approach. Coming to the third approach of brachial plexus, which is called as what? Which is called as axillary approach. Axillary approach. Now guys, axillary approach of brachial plexus. Axillary means you are introducing the needle from the axilla aiming towards the brachial plexus. You have to use a long needle. But guys, is it the proximal or the distal approach? This is the most distal approach of brachial plexus. As it is a distal approach, it only blocks the distal roots. Hence, it is used for what surgeries? Hand and forearm surgeries. Axillary approach is ideal for what surgeries? Forearm and hand surgeries. With axillary approach, many nerves are spared, but one nerve is exclusively spared in axillary approach. What is the nerve that is being spared over here? Musculocutaneous nerve. Musculocutaneous nerve is being spared, right? And with this axillary approach, you can easily damage the neurovascular bundle. You can damage the NVB. What is NVB? NVB is neurovascular bundle. With this axillary approach, you can easily damage the neurovascular bundle. So once again, guys, brachial plexus can be approached by 3 routes. The proximal is the interscalene, the most common supraclavicular, and the third and the distal is axillary. With interscalene, you are blocking the proximal roots only, C5, C6, C7, hence used for proximal arm surgeries or best used for shoulder analgesia, right? What is the nerve spared? Ulnar. What is the nerve damage? Phrenic nerve. Next is supraclavicular, the best and the most common approach of brachial plexus. Why? Because everything is blocked. Last approach of brachial plexus is axillary approach. In this axillary approach, what we need to remember, with axillary approach, you are blocking the distal roots. What distal roots? C8 and T1 is blocked. The proximal, basically not C8 and T1. Just cut this point of C8, T1, guys, right? With axillary approach, only distal roots are blocked. Okay? Hence used for hand and forearm surgeries, right? So, but the nerve that is spared in axillary approach is musculocutaneous nerve. Musculocutaneous nerve. That was regarding the brachial plexus. That was regarding the brachial plexus block. Okay. Next is what, guys? Next is stellate ganglion block. Stellate ganglion block. First of all, guys, we need to remember what is the stellate ganglion responsible for. Stellate ganglion is responsible for sympathetic activity of the face, neck and upper limb. Stellate ganglion is responsible for sympathetic activity of the face, neck and upper limb. Sympathetic meaning what? The vasoconstrictive activity of the face, neck and upper limb, right? Stellate ganglion is responsible for that activity. Why do you want to block the stellate ganglion? When there is some excessive sympathetic activity, then you have to block it. Such as in the case of Raynaud's disease, there is excessive sympathetic activity that is causing excessive vasospasm, right? Raynaud's disease, there is vasospasm of the fingers and all. There is decreased blood supply to the fingers. If a person of Raynaud's come to your hospital, the first thing we'll give him peripheral vasodilators. If the peripheral vasodilators doesn't work, then we go for what? Stellate ganglion block. Then we go for Stellate Ganglion Block. So remember guys, stellate ganglion block is what? Stellate ganglion, first of all, stellate ganglion is responsible for sympathetic activity of the face, neck and upper limb, right? So when do you want to block the stellate ganglion? When there is excessive sympathetic activity, such as in Raynaud's disease. Apart from that, if there is any drug-induced vasospasm, drug-induced vasospasm, we have discussed one drug, thiopentone. I told you thiopentone, you never given the cubital fossa, it causes severe vasospasm. If thiopentone-induced vasospasm happens, the last result is stellate ganglion block. Okay, so Raynaud's disease, drug-induced vasospasm. Apart from that, what is the other indication of stellate ganglion block? Stellate ganglion block can also be used for post-herpetic neuralgia. If the patient is having pain post-herpetic neuralgia, severe pain after developing herpes zoster ophthalmicus, then you can give stellate ganglion block. Where is the stellate ganglion? Stellate ganglion is present anterior to the process of C6 vertebra. Stellate ganglion, where it is present? Anterior to the process of C6 vertebra. So first you need to locate the stellate ganglion. It is present anterior to the process of C6 vertebra. There is a tubercle called as Chazakne's tubercle. Once you locate it, then you have to insert the needle and you have to give the local anesthetic in the stellate ganglion. Once you are in the stellate ganglion, once you have given the local anesthetic, how will you come to know that you have achieved a successful stellate ganglion block? Stellate ganglion block achievement. The signs of achievement of successful stellate ganglion block, that is very important guys. The signs of achievement, it totally 3 signs you will see. One is the eye sign, other is the ear sign, last is the nose sign. First guys, if you block the stellate ganglion, what will happen to the blood vessels? All the blood vessels will dilate. The blood vessels of the face, the blood vessels of the ear, blood vessels of the nasal cavity, blood vessels of the hand, all will get dilated. But the first sign of achievement of a successful stellate ganglion block usually occurs in the eye. Once you block the stellate ganglion, patient will have features of Horner's syndrome in eye. Features of Horner's syndrome in eye. You know what is Horner's syndrome? Horner's syndrome is characterized by ptosis, meiosis, anhidrosis, anophthalmos, and loss of ciliospinal reflex. Loss of ciliospinal reflex. Ptosis, meiosis, anhidrosis, anophthalmos and loss of ciliospinal reflex. That you see in what syndrome? Horner's syndrome. Horner's syndrome, right? So that is basically the first sign. Achievement of Horner's syndrome is the first successful sign of stellate ganglion block. Apart from that, you will see Gutman's sign and Muller's sign. What is Gutman's sign? Patient will tell the doctor, I am not able to smell from my nose. Okay? Why? If you examine his nose, you will see what? You will see dilated blood vessel. So vasodilation of the nasal mucosa is called as Gutman's sign. Vasodilation of what mucosa? Nasal mucosa is called as Gutman's sign. Then there is Muller's sign. Muller's sign is what? The patient will tell the doctor, I am not able to hear from my ear. Why? Because you just examine his ear by otoscope, you will see what? Dilated blood vessels on the tympanic membrane. So basically vasodilation of tympanic membrane is called as Muller's sign. So 3 signs of achievement of a stellate ganglion block. One is achievement of Horner's syndrome. Other is Gutman's sign, which is vasodilatation of the nasal mucosa. Last is Muller's sign. What is Muller's sign? Vasodilatation of the tympanic membrane, right? These are the 3 signs of achievement of stellate ganglion block, right? Coming to the last block, guys, which is called as Celiac Plexus Block. First, once again, we have to discuss about what? Celiac Plexus. What is Celiac Plexus responsible for? Celiac Plexus is responsible for, come on, it supplies what? It supplies the gastrointestinal tract. Celiac Plexus supplies the gastrointestinal tract, the stomach, the duodenum, right? The pancreas, the gallbladder, all are supplied by what? Celiac Plexus. Celiac Plexus. That's a large plexus. You normally don't go for Celiac Plexus block in every other case. Celiac Plexus is only indicated for terminally ill patients. Terminally यानी कि basic patient having terminal abdominal cancer, patient suffering with any abdominal malignancy, terminal abdominal malignancy, and having severe abdominal pain, not responding to any medication, you go for Celiac Plexus. The reason why Celiac Plexus is not routinely done, why? Because first of all, it is supplying a major gastrointestinal tract. Second, it comes with a major complications, guys. What major complications? First of all, you need to understand where is the Celiac Plexus present. The Celiac Plexus is present between T5 till T12. T5 till T12. It is not that it is present in between the vertebrae. In between the vertebrae, you will find what? The space for spinal and epidural. Celiac Plexus is present present beside the T5, T6, T8, T7 till T12. Right? Beside means very deep inside the T5, T6 vertebrae, Celiac Plexus is present. Celiac Plexus is present. Okay? This will be the skin of the back. Celiac Plexus will be present deep inside, beside the bodies of T5, T6, T7, T8, T10, T9, T10, T11 and T12 vertebrae. If you want to block the Celiac Plexus, same like spinal anesthesia, you go behind the patient, you clean the back, you take the needle, you insert the needle beside the bodies of T5 or T6. As you are inserting the needle over there, what will happen? You have to take a long needle. Why? Because Celiac Plexus is very deep inside. As you insert the needle, what can happen, guys? There are some major blood vessels such as inferior vena cava, abdominal aorta. Your needle might damage the inferior vena cava or abdominal aorta. The moment your needle damages the inferior vena cava or abdominal aorta, what will happen? Will the patient tell you that my inferior vena cava is gone or abdominal aorta is gone? No. What will happen, guys? Within no time, patient becomes pale and within no time he will collapse. Why? Because you have damaged his large blood vessel. So this block comes with a major complications. What major? Damage to the abdominal aorta or damage to the inferior vena cava could be seen with this Celiac Plexus block. So indication, what is the indication of Celiac Plexus, guys? Right there, first indication of Celiac Plexus. For what surgery you go for Celiac Plexus? Patient suffering with terminal stage abdominal malignancy, terminal stage abdominal malignancy, having severe abdominal pain, which is not responding to any medication, which is not responding to any medicine, there you go for Celiac Plexus. Then and there you go for what? Celiac Plexus block. That is the only indication. Why don't you go routinely? Why? Because the Celiac Plexus comes with complication. I told you Celiac Plexus is present between T5 till T12, right? Where you can block the greater, lesser and the other splanchnic nerves, right? Celiac Plexus indication we have already discussed, no need to discuss it. Coming to the complication, guys. The complication of Celiac Plexus, come on. What is the complication of celiac plexus? With celiac plexus block, there is much chance to damage the inferior vena cava or damage the major blood vessels such as abdominal aorta. Abdominal aorta. So this was regarding the celiac plexus block and the other nerve blocks, guys. Okay guys, thank you.